Hello again, friends. Our talk here will be on endometriosis. This is quite common. You'll come into contact with this quite a bit if you see women in family practice. So I just want to preface this by saying that this is a medical lecture. So I know there are a lot of people who watch my videos who are looking for information on different diseases that are non-medical professionals. And I just want to indicate that it is important that you talk to your physician about endometriosis or any of the other medical disorders that I talk about in my lectures. Talk about this with your physician. Don't just gather information here and try to make a diagnosis. I know that I have people that will ask me to make a diagnosis in them. I don't do that. I don't diagnose patients that I don't see. So please talk to your physician about any disorder you think you might have. Don't rely on these lectures to make a self-diagnosis. All right? So we'll start with a vignette. We have a 28-year-old woman presenting to your clinic complaining of cyclical pelvic pain for the past year. She says that it has remained constant, which she rates at about a 4 out of 10. But it seems to get predictably worse in the days leading up to her period. She denies any pain on urination and has had only 2 bladder infections in her life. Past medical history is unremarkable. She's never had any STDs, no significant family history, no surgeries. She's not on any medications. She denies drinking, smoking, and drugs. She's monogamous with her fiance and says that occasionally she has some mild discomfort during sex. She has never been pregnant as far as she knows, but is considering pregnancy after she gets married next spring. Her cycles are regular, about every 26 to 28 days. Abdomen is soft, non-tender, non-distended. There's mild pelvic pain on palpation. The vulva and vagina are normal. Speculum exam is unremarkable. Bimanual exam reveals uterosacral nodularity, adnexal tenderness, and the uterus is retroverted. You don't note any masses, no adnexal masses. So what do you do with this patient? There's a lot of things that could be going on in this patient. One thing that we're most concerned about, although not so much with her, but we're always concerned about in any woman who has pelvic pain, is going to be pregnancy. And so we always want to get a beta HCG. We'll get that in her. The urine HCG is negative. We'll also go ahead and get a urinalysis and CBC. Those are within normal limits. You always think possible bladder infection, although again, this has been chronic pain, no pain on urination. This is just pelvic pain, which only seems to get worse with her periods and a little bit of dyspareunia with sex. So all of that is negative. We could probably also get vaginal and cervical swabs to look for STDs. She doesn't seem to have any risk factors. She's monogamous. She doesn't have any discharge noted on speculum examination, but we'll get swabs too, and those are pending at the moment. But we can, for the most part, we can assume that those are probably going to be negative, just based on our history, although we do want to get them anyway. So all these labs are normal, but we do note this nodularity, there's pelvic pain, there's adnexal tenderness. So there's still a variety of things that this can be. However, endometriosis is the most likely. Endometriosis pain is not always cyclical, but when you do have cyclical pelvic pain, the red flag should go up for endometriosis, especially when it is predictably right around periods, a day or two before menses. And then the uterosacral nodularity is very characteristic of endometriosis, but not all patients with endometriosis will have uterosacral nodularity. All right, we'll go over the pathophysiology of endometriosis as well as the epidemiology and risk factors. We'll talk about how this presents. We had a pretty classic case here. And then we'll go about how we work this up and then the treatment modalities. Endometriosis is the presence of endometrial glands, just endometrial tissue outside the normal location where it should be. It should be in the inner part of the uterus. Now this excludes adenomyosis. We're not going to talk about adenomyosis here, but adenomyosis is similar to endometriosis in that the endometrial tissue is in a place where it shouldn't be, But with adenomyosis, it is in the muscular layer of the uterus. So it's not outside the uterus. It is still in the uterus, in the uterine tissue, but it's in the muscular layer. Now with adenomyosis, you're going to have a confluently enlarged uterus. Not the case with endometriosis. You can have nodules. You can have nodules outside the uterus. And so it's similar in as much as you can have pelvic pain and the pathophysiology, as far as the uterine tissue being not where it's supposed to be, is similar, but these are really two distinct processes. This is a hormonally dependent disease. Remember, what your endometrium does is it changes with hormones. Estrogen is going to cause the endometrial lining to thicken up and become nice and lush for hopefully a fertilized, or maybe not hopefully, but hopefully for a fertilized egg to implant. And so this is hormonally dependent. Now there is some unique pathophysiology that goes on in the endometriotic implants, we call them, just the abnormal endometrial tissue that is where it shouldn't be, which we associate with endometriosis. And so there are some things that happen there that don't necessarily happen in normal endometrial tissue. Namely, they can convert androgens to estrogens. They have an increased level of cyclooxygenase, and so there's some different things that can go on there, but really don't have to be too concerned with that for diagnosis and management. But this is endometrial tissue here that we're talking about in endometriosis, and it's just where it shouldn't be. It presents chiefly in reproductive age women. Why? Because reproductive age women have higher levels of estrogen. Pre-pubertal patients don't have that. Postmenopausal patients don't have that. So reproductive age women tend to be who this presents in. After menopause, endometriosis gets a lot better. The most common presenting symptom is chronic pelvic pain, which may or may not be cyclical. As I mentioned, the endometrial tissue, the abnormal endometrial tissue, this endometriotic implants, they can create their own estrogen. And so it doesn't necessarily have to respond to the estrogen that's made from the ovaries. You can have chronic pelvic pain because this tissue can make its own estrogen. So it does not have to be cyclical pelvic pain. It does not have to be associated with menses, but in many cases it is. As I mentioned, it's not the same as adenomyosis, though some of the symptoms may overlap. Oh, and yes, the endometriosis should always be considered on the differential of any kind of ongoing chronic pelvic pain, as well as the differential for infertility and subfertility. So I believe about 40 to 50% of patients with pelvic pain will have some level of endometriosis, and about 20 to 50% of patients with infertility will have some level of endometriosis. Right, so moving on to the pathophysiology. The exact pathophysiology has not been discerned. There are some various theories that are out there. The retrograde menstruation theory has been out probably the longest, for several decades. All this is postulating is that there's a dissemination of endometrial fragments that occur because of retrograde menstruation. So you have abnormal peristalsis of the uterus. Rather than peristalsing the menstrual contents out of the cervix and into the vagina, you have a retrograde menstruation where some of the contents are spilling out. They're going through the tubes and out into the peritoneum. That is not what should normally happen. And what we have found is that women with uterine hyperperistalsis or dysperistalsis have a higher incidence of endometriosis. What we also know is that women with outflow tract obstruction, so if you think about it, if you can't get the contents of the uterus out, then it can go backwards when the uterus contracts. Women who have outflow tract obstructions, they also have an increased incidence of endometriosis. So that can be things like a transverse vaginal septum. That can be like a unicornuate uterus, where you have that rudimentary uterus, which can menstruate, but it can't get out the cervix because there's no connection there. And so there are various disorders that can result in retrograde menstruation. Lymphatic and vascular spread possibly can explain the fact that we find endometrial tissue in unusual sites. So in very rare cases, you can have endometrial tissue way outside of the uterus. I've even heard of it being in the lungs. So that may be a possible explanation for that. And we also know that endometrial cancer typically spreads through the lymphatic system. However, there's been little experimental evidence to back this theory up. Another explanation theory is coelomic metaplasia, and what this suggests is that you have parietal peritoneum, which exists all over your peritoneum, and that tissue can undergo change, and it can change into tissue that's similar to the endometrium. Why that happens, we don't really know, but that is a theory. Now, because the coelomic epithelium is the progenitor of ovaries and Müllerian structures, it does have the potential, theoretically, to change into uterine tissue because it is the progenitor for that. And this can also explain instances of endometriosis in the patient populations where we don't expect to see it. So pre-menarchal, pre-pubertal patients, postmenopausal patients, as well as men. Yes, men can have endometriosis. Crazy, isn't it? But if you have this tissue, which can turn into anything that relates to testes, ovaries, Müllerian structures, yes, it can happen in men because when we start out embryologically, we have the potential to change into all these different tissues. We have cells that can turn into these tissues. And so if you have a man who is on estrogen, he may have this tissue, this endometrial-like tissue, and when he takes estrogen, that winds up causing these symptoms of endometriosis. Now, normally in a man, he doesn't have enough estrogen to develop symptoms, but if he takes estrogen for one reason or another, then he can develop he can develop this endometriosis. So let's say, for instance, he has a hyperestrogenic state because he's got liver failure, for instance, or he's taking a drug that induces a hyperestrogenic state. For instance, I think BPH, there's some of those drugs can do that. So that can be a possibility. I've never heard of a case where that's happened, but apparently it does happen because I read about it in the text that I got this stuff from. Other theories are what's known as the induction theory. This idea is that any kind of exposure to estrogen or higher amounts of estrogen can cause transformation of certain tissues to endometrial-like tissue. So it's similar to this metaplastic theory. And then immune dysfunction. I didn't look too much into this because it looked really complex. There's all these mediators and everything. But suffice it to say that if there's a localized impaired cellular or humoral immunity, it can change the cellular biology enough to where you get increased estrogen developing in endometrial tissue. So none of these theories really explain everything that we see in endometriosis, so it's probable that it's a combination of these theories, or it might be something else altogether. Don't worry too much about this for any kind of test-related purposes. This is just to satisfy your curiosity and hopefully give you some kind of underlying idea of what might be behind this. The epidemiology, the estimated incidence of endometriosis is reported at approximately 1.6 per thousand, but that is surgically diagnosed endometriosis. Now, in a lot of patients, we will go on to diagnose the endometriosis surgically. We go in with a laparoscope, we see endometrial tissue, it's sort of reddish or bluish in color or even white, and then we diagnose it surgically. However, in a lot of patients, we'll make a presumptive diagnosis clinically and we'll leave it at that, and we treat them and it goes away. So symptoms get better and we continue treating them and we don't need to do laparoscopy. So this is just surgically diagnosed endometriosis, but the incidence in reality is likely much higher. So for non-surgically diagnosed disease and subclinical endometriosis, a lot of women will have endometrial tissue that's outside the uterus, but it's not significant enough to where they where they have symptoms. And I just want to point out that the symptoms of endometriosis, the severity of symptoms, are not related to how much endometrial tissue there is outside the uterus. You could have endometrial tissue all over outside the uterus and not necessarily have symptoms. What it is related to is the depth of invasion of that tissue. That will correlate more with the symptoms. Evidence has indicated that incidence is higher among East Asians than among whites, and among whites more than blacks. Usually with this sort of paradigm of East Asians being more affected or less affected than whites, being less affected than blacks, usually Hispanics fall somewhere in between whites and blacks, but I'm not sure. This is all I found in the literature. Risk factors. So we know it runs in families. There's no real Mendelian inheritance. We don't know of any specific genes that are affected, but we do know that it happens in families, and that if a woman has endometriosis, there's an 8.1% chance that her mother has it, and a 5.9% chance that her sister has it. So there's increased incidence in first-degree relatives. Women who have severe pain from endometriosis, severe symptoms of endometriosis, are far more likely to have an affected first-degree relative. Women who don't have an affected first-degree relative are more likely to have the mild or moderate form of endometriosis, but there's definitely overlap. There are some candidate genes that may be associated with endometriosis, but there's not any one gene. So one of the genes that has been implicated is EMX2, which is associated with reproductive tract development. The other one is the famous PTEN gene, which is a tumor suppressor gene. Other things, anatomic defects. So as we already mentioned, outflow tract obstruction increases your risk of endometriosis. So this can be various things: the non-communicating uterine horn that we see in unicornuate uterus, the imperforate hymen, transverse vaginal septum, anything that blocks the outflow tract. And it is for this reason that when we diagnose these disorders, we often get a diagnostic laparoscopy to look for endometriosis with these anomalies. Although a lot of times with some of these outflow tract obstructions, we'll get a laparoscopy anyway, but that should be noted. Environmental toxins can be implicated. TCDD, I don't remember exactly what that stands for, but it's an industrial waste product that can contaminate foods. That's been implicated. It can cause an upregulation in the transcription of various genes. Caffeine and alcohol use have been associated with endometriosis. Interestingly, smoking, cigarettes, nicotine, has been associated with less endometriosis. That does not mean tell your patients to smoke if they have endometriosis, but there is that association. Also, exercise reduces risk of endometriosis as well. So how does this present? As mentioned, the most common presenting symptom is chronic pelvic pain, which may or may not be cyclical. Depending on where the endometrial implants are, it can radiate. So it can be localized to the pelvis, or it can radiate. Usually if it's on the uterosacral ligament, it can radiate to the upper back. If it's in the posterior peritoneum, it can radiate down the leg. The pain symptoms, as mentioned, can be cyclical, or it can just be chronic, not associated with not associated with menses or anything. The cause of the pain symptoms is unclear, but it is likely related to the fact that, as I was previously alluding to, this abnormal endometrial tissue has higher amounts of cytokines and prostaglandins. Remember, there's an increased amount of COX-2 in this endometrial, this abnormal endometrial tissue, this endometriotic implants, they call them. And so if there's an increased amount of COX-2, you're going to have more prostaglandins, and prostaglandins also have an effect of inducing aromatase. And when aromatase is induced, what it does is it converts androgens to estrogens. And estrogens, particularly estradiol, actually induces COX-2. So you get this positive loop going on where you've got COX-2 creating prostaglandins inducing aromatase, aromatase causing the creation of estradiol, and estradiol inducing COX-2. So you get this cycle which ultimately increases estrogens and increases prostaglandins. And it's probably the prostaglandins that is causing the pain as well as other cytokines. So again, remember that pain is not correlated with the extent of the disease, how much endometrial tissue is sitting outside the uterus, but rather the depth of invasion. Dysmenorrhea is very commonly described with endometriosis. Usually when this happens, the pain will precede menses by around 1 to 2 days. Compared to primary dysmenorrhea, remember that's the dysmenorrhea that typically comes on when girls start having their first periods and it's painful. Remember how we treat that is we treat that with NSAIDs or oral contraceptives. With dysmenorrhea associated with endometriosis, it tends to be less responsive to NSAIDs and oral contraceptives than is regular old idiopathic primary dysmenorrhea. That doesn't mean that there isn't some response, but it's typically not enough to satisfy the patient. There'll still be some pain remaining. Dyspareunia is quite common, especially when there's uterosacral implants. And so this is what we saw in this patient. The uterosacral ligament gets mechanically disturbed, moved around during sexual intercourse. That's a ligament that connects the uterus to the sacrum. It sort of sits underneath the uterus if you're laying down, and so that can get disturbed and cause pain. It's not the ligament that's in pain, it's the endometrial implants that sit on that ligament that are very tender, and that's what's causing the pain. Dysuria can happen if there's any kind of implants around the urethra. Remember, the urethra sits very close to the uterus as well, so that can happen. Defecatory pain is less common, but you can get implants around the rectum, as well as along the small bowel, the appendix, and the cecum. The other major thing you're going to see with endometriosis is infertility, and this should always be on your differential for patients with infertility. The problem that leads to infertility is just a disruption of the tubal architecture. You also can get endometrial implants on the ovaries, and that can disturb folliculogenesis. So there's various things that can lead to the infertility from endometriosis. All right. Oh, and then I wanted to quickly talk about intestinal and urethral obstruction. So if you have a patient with intestinal obstruction, sorry, it's 4th of July was a few days ago. People are still lighting fireworks out here. Anyhow, if you have a patient with intestinal obstruction, what's the first thing you might do? You might get imaging. On CT, endometriosis that invades the bowel is going to look almost identical to malignancy. And so what we go about doing in that case is we get a laparoscopy. Generally the symptoms will help, the clinical history and everything. We'll get a laparoscopy, and that will definitely help you exclude malignancy. You probably need to remove that mass and get a biopsy just to be extra sure. If you get urethral obstruction, that's going to lead to increased frequency, increased urgency, difficulty with urinating. Of course, if there's obstruction, you won't be able to urinate. That can ultimately lead to post-renal failure, so you have to keep an eye on that and treat that as necessary. You'll get a urologist to manage that. Physical exam. So visual inspection is going to be normal. There's nothing wrong with the vagina or the vulva. Speculum examination is also going to typically be normal. Only about 14-15% of patients will have lesions more externally, so on the cervix or possibly the posterior fornix of the uterus. And when they do show up, they're going to be usually blue, occasionally a deep red color, and they'll be friable and they'll easily bleed. So that will help you distinguish them from some of the other lesions that you see in that area. Bimanual examination will vary greatly, and it really just depends on the extent of the disease. So uterosacral nodularity and tenderness, very common buzzword for tests, so you should be aware of that. So you do the examination, you're palpating the uterus, and you feel posteriorly, you feel this sort of nodularity as you move the uterus around, and it's going to be tender as well. A fixed retroverted uterus, remember the uterus should come anteriorly as you move up the cervix. If it's retroverted, that's abnormal. Now, some women just have a retroverted uterus, and that's just their normal anatomy. But in this case, you'll have a fixed retroverted uterus, or you may be able to manipulate it a little bit, but it'll be fixed and retroverted. Not all women with endometriosis have this, but this is common, and again, this is something that often comes up on a test question. You may note an adnexal mass. This is the endometrioma, and we'll see a few pictures of that. You can also note, in some cases, a fixed, firm posterior cul-de-sac, and that cul-de-sac is just the sort of potential space in between the uterus and the rectum. What do you do for workup? We already did this. You want to get a CBC, look for any kind of systemic signs of infection. You want to get a urine HCG, rule out pregnancy. That is a big rule in OBGYN. Anytime you have a patient with pelvic pain, you're always getting an HCG. Why? Rule out ectopic pregnancy, which can be an emergent problem. If it goes undiagnosed, a woman can die from it. So always, always, always pelvic pain, HCG. Any woman from, I would say, age 11 to, I would say, 65. I would not be conservative about this at all. HCG tests, urine HCG, very, very, very cheap. These are the tests you can get over the counter, pregnancy tests. Urinalysis and culture, looking for UTI, anything else that might be in there, interstitial cystitis is a possibility, and then vaginal cervical cultures looking for STDs and other infections. Imaging. First imaging test you're going to get for endometriosis is the transvaginal sonography. There's other sonographic imaging techniques that can be done. You can get a transabdominal sonography. You can also, there's also I can't remember what it's called, but basically what they do is they inject fluid up into the vagina and into the uterus, and it helps you sort of, it helps you distinguish some of the anatomy a little bit easier. I'm trying to remember what that's called, and it's driving me nuts now. Anyway, other tests that can be done are CT and MRI. Those can be done in select cases, like for instance, if you have like a bowel obstruction or something like that, and you can go ahead with that. MRI is used by some gynecologists, but as far as the test is concerned, transvaginal sonography is going to be your mainstay for imaging. You want to get lab tests first, then go ahead with imaging. The best test, the most definitive test, is diagnostic laparoscopy, because you're going to be able to visualize that tissue, and it has a pretty characteristic appearance. The color of the tissue of the endometrial implants can vary, but typically they're either red or white, sometimes bluish purple. And they'll be sort of these little nodules, or they can be sort of a stellate pattern, but that's how they will appear. Now, if you want to be technical about it, the most accurate test is going to be a biopsy. But because we have a clinical picture, we have a patient with pain, possibly infertility, and then we get a sonography, and that's consistent, and then we go ahead with laparoscopy, and that's consistent, we typically don't need to get any kind of biopsy. Okay, so laparoscopy is effectively your most definitive means of diagnosing endometriosis. However, in most cases, after you get sonography and it's consistent with endometriosis, you're going to go ahead and manage this medically. And you can do things like contraceptives, you can even do the GnRH agonists, and you can try those things, and if they work, particularly if the GnRH agonists work, then you can diagnose endometriosis clinically. And as a matter of fact, the American College of Obstetricians and Gynecologists have now said that if you try NSAIDs and oral contraceptives and they don't work in a patient that you're suspecting endometriosis, but then you go ahead and try GnRH agonists and that makes the pain go away, then you can diagnose endometriosis just from that. Okay. So that brings us, we're going to look at some pictures here. Okay, so this is transvaginal sonography. I don't want you to get bogged down with this too much, but we do the sonography through the vagina. We look behind the uterus, and that's where the uterosacral ligament would be. Now, the uterosacral ligament is just confluent tissue. And so normally we don't see anything too remarkable there. But if you see these little masses behind the uterus, that can be uterosacral nodules. Now, I'm not a radiologist, so if you want to get more information about this, go ahead and look online. But you look behind the uterus and you see these nodules, they're often uterosacral nodules. And they're hypoechoic. So here's endometriosis. You see the uterus here, the ovaries are out here, and these little nodules here, these are brown. They're not always brown. Usually they're red or white, but this is just oxidized blood. Okay, so you see them over here along the ovaries. Okay. This is you'll see this a lot if you ever scrub in for a laparoscopy in a patient with endometriosis. You'll see these little nodules here. They look just like this. Usually red, deep red. Sometimes you'll see them, they'll be white. They can even be sort of a clearish translucent color. But red and white are the most common colors. But it can be such a deep red that it almost appears a sort of brown color, and that's just the blood being oxidized. Okay, so here again we see nodules. These are on the anterior aspect of the uterus. Okay, this is a cyst. So this is an endometrioma, and this is on the ovary. And what's going to happen is you see this cyst, and the surgeon will go in and make a little hole, and all of this dark reddish-brown blood will pour out of it. We call this a chocolate cyst. I'm sure a pathologist came up with that name because pathologists love to name things, even disgusting things, after food. So this is a chocolate cyst. Yes, it does kind of look like chocolate syrup, I suppose. It's just going to ruin chocolate for me. All right, and this is another chocolate cyst. Here we don't see the chocolate coming out of it, but this is also the endometrioma, which sits on the ovary. Now, when you remove this, and you should, because any kind of ovarian mass we need to get a biopsy on, when you remove it, you want to preserve as much of the normal ovarian tissue as you can, because if you remove too much, you're going to remove eggs, and that's going to reduce the woman's fertility. So you need to be careful. And then here we have endometriosis of the uterosacral ligament down here, and then also of the ovarian fossa. All right. So the differential diagnosis, we always think of possibly pelvic inflammatory disease anytime you have a patient with ongoing pelvic pain. These can be things like tubo-ovarian abscess, salpingitis, endometritis. A lot of times these will be more of acute on chronic. With tubo-ovarian abscess, you probably have a significant fever, but this is going to be more of an infectious picture than endometriosis. You won't have a fever with that. Hemorrhagic ovarian cyst, really can't tell the difference between this and the chocolate cyst just by looking at it. However, you won't have other signs of endometriosis, so you're not going to have the uterosacral nodularity. You won't have these implants elsewhere. They'll just be the cyst. Ovarian torsion, this is acute pain, not chronic pain. Primary dysmenorrhea typically comes and goes with the cycles, and also is going to be more common in younger women. They won't have any of the other findings you see in endometriosis. Degenerating leiomyoma, typically patient with a history of fibroids. You'll only see these nodules, these fibroids in the uterus. And then, of course, an ectopic pregnancy, which is easily diagnosed with a urine pregnancy screening. Non-gynecologic causes include chronic UTI. These patients typically have an extended history of urinary tract infections. Interstitial cystitis. You can differentiate this by getting your urinalysis. Renal calculi, again, more acute. And a lot of times, patients with kidney stones will have a history of kidney stones. This is just one of those things that some people just get it over and over again, kind of like UTIs in certain women. There's some women that just get it a lot, and there's some people that just get kidney stones a lot. GI disorders. So occasionally with endometriosis, you can get diarrhea, constipation. You should always, in those cases, be looking for implants on the bowel. But there are GI disorders that can cause constipation, can cause diarrhea. Remember, endometriosis, this tissue is friable. It can bleed. And so patients with endometriosis can occasionally get hematochezia. That can look like inflammatory bowel disease. So this is something to rule out if you have that presentation. Diverticulitis, not common in young people. And that tends to be the patients that endometriosis presents in. Barium enema will help you differentiate that's diverticulosis. But I wouldn't worry about diverticulitis. This is more in much older people, especially in this country where we don't get enough fiber. You get diverticulosis and diverticulitis from that. CT would help too. Musculoskeletal disorders, that can be a variety of things that can cause chronic pain. Medical management. So treatment is going to depend on a lot of different things. We don't even need to treat all patients. Now, some patients will have endometriosis and the pain will be so mild and they have adversity to medications. They just don't want to take something. They don't want to take medications. And so we can just watch and wait with that. But most patients, when they come to you with a complaint and they want it to be addressed. So most patients, you're going to be treating them. What do you want to know? You want to know the specific symptoms. You want to know the severity of the pain. You want to know where it's at, and you want to know what their desire is for future fertility. Now, there are some women that they don't want to have any more children, and in those cases, why even bother with medical therapy? Why not just do a hysterectomy? You'll want to take out the ovaries too, but why not just take those organs out, and for the most part, you will have cured the endometriosis. You can do that, but most women, because they're of reproductive age, they will want to maintain some level of reproductive potential, but it really just depends, okay? Medical agents that can be used. NSAIDs are typically the first drug we go to. Now, you're not going to use NSAIDs so much in patients who have diagnosed endometriosis, surgically diagnosed endometriosis, but this typically is the first drug we go to. Combined oral contraceptives is more of the mainstay of endometriosis. So a patient who has endometriosis and we've diagnosed it, this is if you have a group of patients, you have a room full of women who have endometriosis that's been diagnosed, most of them will be on combined oral contraceptives. Progestins, androgens, GnRH agonists, aromatase inhibitors. You've heard me refer to these earlier. We're going to talk about these in greater detail. So NSAIDs are usually the first line of therapy. Who do we use NSAIDs in for gynecologic purposes? We use them in patients with primary dysmenorrhea. So that's going to be your go-to drug in a younger woman with primary dysmenorrhea. You'll remember that 15-year-old girl comes to you complaining of painful periods, NSAIDs. Ibuprofen, naproxen, ketoprofen, any of those are good. Pelvic pain, pelvic pain before laparoscopic confirmation. So if you have not diagnosed it and confirmed it laparoscopically, surgically, you use NSAIDs. Now, there is I don't know why I put primary here. There is an exception, and I mentioned that exception. So I'll make note of that later on after we talk about GnRH agonists. And then confirmed endometriosis if they just have mild symptoms. So if they just have mild symptoms, and particularly if they want to get pregnant, then you don't want to use oral contraceptives on them. So if it's just mild symptoms, you can stick with NSAIDs. The mainstay of therapy, as I mentioned, is combined oral contraceptives. Why does this work? It works because you decrease GnRH. That's going to decrease menstrual flow. It decidualizes the implants. And by doing that, you reduce the symptoms. If you can decidualize the implants, you're not going to have all this production of of the prostaglandins and cytokines inside that implanted tissue. Progestins, there's a ton of these that you can use, and essentially they do the same thing as the oral contraceptives. They decidualize the tissue, they cause atrophy. There are various ways that these can be administered. There's DMPA, Depo-Provera. This unfortunately has an adverse effect, and that is it decreases bone mineral density, so you don't want to use this for very long. Norethindrone can be given orally. It's very effective given alongside the GnRH agonists like Lupron. Some other ones, levonorgestrel. This is an intrauterine device that can be implanted. It's known as Mirena. You put it in, you can leave it there for 5 years. I think it's 5 years, I'm pretty sure. Okay, that's the Mirena though. You put it in, you leave it in, you don't have to worry about going in for shots, you don't have to take oral pills, you just leave it there. A lot of women find that pretty convenient. Adverse effect from that, weight gain. So if a woman's very sensitive to gaining weight, might not be the best choice. Ulipristal, otherwise known as ELA, is a selective progesterone receptor modulator. This works a little bit differently, but this is taken orally. And then mifepristone, the notorious RU486. This is an abortifacient. It is not FDA approved for endometriosis, but a lot of physicians have found that it works really well. Just make sure you get a urine pregnancy test first. That's going to be part of your workup. But with any of these drugs that muck around with a woman's hormones, you want to get a urine pregnancy test. Just make sure she's not pregnant before you commence these drugs. Because if she is pregnant, she probably does not want to have a miscarriage. Androgens. So we don't use androgens so much anymore. And the reason is because we have better drugs, and also because androgens cause a really, really bad profile of adverse effects. So think of anything a woman with PCOS can get, polycystic ovarian syndrome. She gets acne. She gets hair growing in places that are unsightly. She can get deepening of the voice. She can get irritable mood changes. She can get hot flashes. We're also concerned about her liver enzymes going up and about her cholesterol levels going up. So all sorts of adverse effects we like to avoid. However, they are pretty effective. So you'll see occasionally danazol being prescribed for women with endometriosis. Another one, I've never seen it prescribed, but it's called gestrinone. And I immediately recognized that drug. That is used in doping. The International Olympic Committee has banned this drug because it's got anabolic effects. It can help you build muscle. Makes sense. It's an androgen. The GnRH agonists, these are very effective. And what these do, you think GnRH agonist. Why do I want to give an agonist of GnRH? That's going to increase estrogen. That's going to increase all these sex hormones. And yes, it does, naturally. So naturally, GnRH will increase those gonadal hormones, but it's because it's pulsatile GnRH. The GnRH is released in a pattern. And if you disrupt that pattern by giving GnRH exogenously, it's going to disrupt the release of estrogen and the sex hormones, and ultimately it'll stun your body, and you won't have estrogen being released. So it's an agonist, but it works because you disrupt the pulsatile release of GnRH. So you have a constant GnRH level, and so no estrogen being released from the ovaries. This can be given as Leuprolide, or known as Lupron. That is given intramuscularly as a depot. And other ones are Goserelin and Nafarelin, which I have never seen before. But Nafarelin is it's expensive, but it can be given to patients whose insurance can cover it. And some women will prefer this rather than getting shots. You can take Nafarelin, and this is a nasal spray, which you take twice a day. So it really just depends on their preference. And then aromatase inhibitors, these are second-line treatments. Reason is because of the fear of decreasing the bone mineral density. And the longer you're on these drugs that decrease bone mineral density, the worse it's going to be. So this is a second-line treatment, but it can be given to patients who are refractory to these other drugs. Anastrozole is the drug that is given. Where else do we see anastrozole? You should know this for the test. You see it in women who have estrogen and progesterone receptor positive breast cancer. You'll give anastrozole as part of chemotherapy. And if you do give this drug, a lot of times you'll give it with bisphosphonates because that will help with the bone mineral density problem. Other potential agents that are being investigated, there's a couple of them that are already FDA-approved drugs. Not FDA-approved yet for endometriosis, but they're used for other things. Simvastatin. So simvastatin is HMG-CoA reductase inhibitor. If it works for endometriosis, that would be really good because if you gave it along with other drugs that may, so like the androgens or anything that's anti-estrogen, you can prevent that dyslipidemia from happening, and so you can fix that. But that is one drug that's being looked at in its own right for helping with endometriosis. The other one is rosiglitazone or Evandia. Now, Evandia is kind of a notorious drug because it's been associated with various problems, and it was actually recommended to be withdrawn from the market, but the FDA kept it on. That is a thiazolidinedione, and it's used for diabetes, type 2 diabetes. But that has been shown to abate some of the symptoms of endometriosis as well. Okay, so lots and lots and lots of drugs. Now, another thing I do want to bring up, with these GnRH agonists, what we know about these, and really a lot of these drugs, but the GnRH agonists, because they're used so much, and because they decrease estrogen, remember that you have GnRH, that it's not pulsatile anymore, you're giving it in a constant amount, and so your ovaries are not releasing estrogen. Because you induce that hypoestrogenic state, and you can get problems with decreased bone mineral density and issues like that, there has been this idea thrown around, and it's actually done now, called add-back therapy. And the idea of add-back therapy is that you can give estrogen to patients with endometriosis. If their estrogen level stays below a certain level, they're not going to have symptoms from endometriosis. So you're keeping them at this sort of critical point. We don't really know exactly where that critical point is, but if you just small amounts of estrogen is not going to induce endometriosis symptoms, and it actually can protect you against some of the adverse effects like decreased bone mineral density. So you can give things like norethindrone, transdermal estradiol, and if you give it in a small enough amount, you can abate some of these problems that you get with the GnRH agonists while still not disrupting the endometriosis and causing symptoms. So that's called add-back therapy, and it can be done with the GnRH agonists as well as other drugs that induce a hypoestrogenic state. Alrighty. Surgical management. Unfortunately, not very effective to relieve symptoms of endometriosis. So you'll see, if you ever see a gynecologist go in and do laparoscopy, look for endometriosis, as a matter of courtesy, a lot of times they'll ablate some of the lesions, remove some of the adhesions, but it's not really been shown to be very effective. These things come back. Now, in the case of endometrioma resection, that's one surgery that a lot of times we'll have to do because it's a painful pelvic mass. Presacral neurectomy, effective in some patients, but it's not a very common procedure. The one surgical management that you do see and that you do need to be aware of for endometriosis is the hysterectomy with bilateral salpingo-oophorectomy, hysterectomy with BSO. This is the most definitive surgical management and can be considered in women who are done bearing children. This will really help the endometriosis. You take the ovaries out, no estrogen. You take the uterus and all those surrounding structures out, you get rid of a lot of the endometrial implants. So this will really help, but the problem is she's no longer fertile. So only in women who are sure they don't want to have any more children. Okay, so here is an algorithm that you can use. So you have a patient suspicious for endometriosis, get a history, get a physical, get your labs, get a transvaginal sonography. If you still think she's got endometriosis, then the way you're going to go about this is by treating her pain or her infertility or both. So let's say her primary complaint is pain. You want to rate her pain. If it's minimal pain, you can just do expectant management. You don't need to treat her. She can have NSAIDs for as needed when she has slightly more pain than usual, but just expectant therapy. Mild pain, you can do NSAIDs. If that doesn't help, you can do combined oral contraceptives. You can also give progestins or GnRH agonists. These are sort of going in order of how, like you'll try NSAIDs first, if that doesn't work, combined oral contraceptives, and you can add on therapies. If it's moderate or severe pain, or if none of these work, the NSAIDs, combined oral contraceptives, progestins, GnRH agonists, if these aren't working, laparoscopy. And you'll make your definitive diagnosis. You can also do any kind of surgical management if you want. Remember, it's not very effective, though. And then from there, okay, we'll talk about that next. Okay, so infertility, you will do an infertility workup. So you want to look at your chromosomes and everything. Check the man, too. Make sure it's nothing else. And if there's symptoms suspicious for endometriosis, that's probably what's behind it. So you can do laparoscopy. You can also just do empiric management for the infertility by giving her clomiphene and trying an intrauterine insemination. So that can help with the fertility. Sometimes, and I'm going on a hunch here, but if you do laparoscopy and there's really significant anatomic issues, that may help by pulling down some of those adhesions. That might help with fertility because it's an anatomic problem, but don't quote me on that. Okay, so once you do laparoscopy, postoperatively, for girls under the age of 16, you don't see them a whole lot with endometriosis, but if you do, combined oral contraceptives. We try to stay away from the progestins and GnRH agonists in very young girls. 16 to 18 years of age, you can do the GnRH agonists or you can do combined oral contraceptives. In girls 16 years of age or younger, if the combined oral contraceptives aren't enough, then in some cases you can do GnRH agonists. For adults, any approved medical treatment is fine. If there is a recurrence of the endometriosis, then you can adjust medical treatment, or if she's done having children, you can do a hysterectomy with BSO. Okay, so hopefully that gives you enough information that you need for endometriosis. If you have any questions, go ahead and write me a note below. What I would be aware of is just your basic, your findings for endometriosis, and then how if you're taking step 3, you'll want to be aware of your workup. Remember to get your urine pregnancy test. Remember to get vaginal and cervical swabs. Remember to get a UA. And then your management, NSAIDs are good, but most women are going to go on to need combined oral contraceptives and likely GnRH agonists. And I did bring this up, but I want to mention one more time that the American College of Obstetricians and Gynecologists have said that in women over the age of 18, where the pain persists despite the use of NSAIDs and combined oral contraceptives, if you give them GnRH agonists and the pain goes away, you don't need to do surgery to diagnose them. You've diagnosed them already. Okay?